Good afternoon, everybody. You're an amazing crowd. Somebody walks up to the microphone and it gets quiet. Like you don't even have to ask, may I have your attention, please? So you already are winners today. I'm very excited that we are together this afternoon because I believe it's something really special that we're doing. Now, we can save the judgment till after the session today. But events like this are so important because they push us to think about who we are as people, what we stand for as an institution, how we must stay connected to the world, and how we can learn from each other. And I think you're really going to enjoy the panel today. And we're extremely fortunate to have Peter Hart with us. He is a quite famous, you wouldn't know it because he wouldn't tell you, he is a quite famous person, a pollster. He works with NBC, the Wall Street Journal. He has managed some of the most difficult town halls. So the fact that he was willing to work with us at Emory to engage in what we're calling conversations with America was quite remarkable. And I'd like to talk just for a second about these conversations with America. People have asked me, so that sounds really interesting, but why are we doing this? And I think everybody in this room, I'm going to assume, and if you disagree, don't tell me now, tell me later. It's so easy at universities in particular. We're all smart people. We're all people that are thinking about what's the evidence for what we're looking at. We're all people who believe that we know how to make a case in an argument. And we talk a lot to each other, and before we know it, we forget what the rest of the world thinks. And I don't know if you ever have had this experience. I recently have had to take a few trips away from Atlanta into more rural areas of Georgia, North Carolina, South Carolina. And I'm not always good making sure that I have enough gas in my car. So then I find myself at quite unusual gas stations. And two things happen. I sort of listen, I'm eavesdropping to what people are talking about. I'm like, boy, this is like a different planet. And this is not just like a few hundred miles away. The next interesting exchange is I start to pay and I say something and people look at me as if I am a true alien because I don't sound like them at all. So, all of this reinforces the notion that we are part of a very complex, diverse world. And that's why we're having these conversations with America, to really break through the bubble that we live in and to get a good sense of what the rest of the world thinks. You hear a lot more about those conversations later today as the panelists talk, as Peter sets it up. And I'm really not going to say much more, but would like to highlight a few aspects. One of the areas that I'm extremely proud of for us as an Emory community is that we are not afraid to have difficult conversations, that we're not afraid to tackle sort of the impossible questions, that we are also not so arrogant that we know what the answers are, but we're just willing to take a risk and challenge ourselves and thereby really advancing the world, really helping the world come up with some of the complex issues that we have. As a social scientist and a public health expert, I actually have, as some of the people in the room know, my co-Houry is here. He and I have known each other for a very long time, have been working on addiction for quite an extensive period of time. But there's something that's different about the opioid epidemic that we currently have in the United States. And I'm not going to take the time to give you a lecture on what I think is different about it, but some of you might have seen my recent op-ed piece in CNN, where you can get a sense of what I'm thinking about. And one of the aspects of that I just can't help myself but will have to say, for those of you who don't know, I grew up in the Netherlands. I spent the first 3 decades of my life, mainly in Europe. And addiction is all over the world. It's not something that happens only in certain places. But the approach towards people who have an issue with addiction, people whose habits get out of hand, is that you can approach it in different ways. So I come from a culture, and I strongly believe in a philosophy that if somebody has a problem, in this case with opioids, the last thing we should do is blame the person and turn them into a criminal, him or her into a criminal. Because at the end of the day, addiction is a societal problem. It's a problem for all of us. It's a sign that something is wrong in the world in which we live. And that means that we collectively really are responsible for not stigmatizing people, for thinking about solutions, and for having the kind of conversations that we're going to have today. So I want to thank you for your commitment to being here, to be part of this conversation, to learn from each other, And I hope that you really will enjoy it. And I now invite the panel to get going and for me to get out of the way. Thank you very much.
President Sterk, thank you very much. I'm delighted to be here. And let me just say, whenever I get introduced as being a pollster, I always worry people say, can you do couches and chairs? So I'm hoping we're not there. And I'm extremely appreciative of all the students that are here and the experts that are in the audience. We have a magnificent panel that I had a good opportunity to meet and talk with, and we are so very fortunate to have this. And I want to talk to you just slightly about the problem, but more importantly, about what I've been seeing. I've been in the public opinion field for now over 50 years. And I've been taking the NBC Wall Street Journal poll for about 30 years now. And what as a society, we've made such an unbelievable advancement in so many areas, whether it be in terms of race or religion or in terms of marriage and all of the other elements. And you would say, this has been remarkable. But at the same time we've been doing this, what's happened is we've really become polarized as a society. And it's no longer a chance that we talk to one another and that we've reached an area of consensus. And so what Emory has undertaken here is the importance of beginning a conversation, the ability to be able to talk to one another to figure out how you reach a consensus. Because as you watch with the United States Congress just last week, and week in and week out, there is no consensus that is being built. And so whether it be the issue of immigration, which we undertook in the fall, or the issue of opioids, which is so important that we're undertaking now, what this is about is having an understanding and a dialogue. And unlike many of the forums that you come to at Emory, this is a town hall. And this is a town hall in which we've got some magnificent experts talking about things, but we want you to talk about it. So you're not just students, you're participants, you're people who see things that are happening, and many of you are scholars in the field. So part of this hour and 15 minutes that we're going to be together is really about hearing from you and not just asking the experts questions, but also giving us a perspective and understanding of where we're at. I should mention that we are indeed recording this, and in doing so, I think we have a few members of the press that are here, so you may be quoted, but also if in the recording you say, I don't want to be identified, just talk to the AV people back there. Afterwards, we'll be able to make that change and adaptation. The thing I will start off with, if it's okay, is to take a look a little of the public opinion data, and then we'll bring the panel up, and the panel will start talking, but I'm going to also interject and bring you into the conversation and hear from where you come from. And probably the best place to start is, and these are polls that have been collected over the last few months, and if you start with all the problems that are facing the American society and where we're at, as you can see, prescription drug abuse has now risen to the top. It is equivalent with cancer at this stage of the game, and the way in which it has just swept across society. We go through various issues over decades, and they start to come in and drop out. But indeed, prescription drugs and opioids is the #1 problem in terms of that. And you can see the growth and the change in terms of where we're going. Indeed, if you look at this, what we've got is 44%. 44% of Americans say, yes, they have and know someone who has been addicted to prescription painkillers. And it's just amazing. How many people, by the way, here know somebody that is close friend or relative that has been attacked? Take a look around the room. And if you went further, a wider swatch of people, it would be half the hands would be up. And if you look at this, it's no longer just somebody that's down the road or somebody that's a neighbor far away. It's right in your own family. It is your own acquaintances. It is your best friends. And if we turn from this to the next page, this just tells you what's happened, how quickly it's happened, and how important a change in terms of society. It is no longer something that is relegated to a small group of people. It is indeed everyone that is there. And you look at this, and then the question is, and this is where we start to cleave and see the difference in terms of our society, and that is, who's responsible and how do we look at it? Do we look at it indeed, and this is a Marist poll, as an illness or weakness? And you start to see why the importance of this conversation. Because while you look and say there's not that much difference by race, and in terms of age groups, there are some differences. But look at the difference between Republicans and Democrats. It's like two different worlds. And you have here that for Republicans, they're equally divided, whether it's a weakness or an illness. If you look at Democrats, they recognize that indeed illness. If you look, the other thing is within the Latino community, look how divided that is. And finally, we always hear this talking about what is the Trump constituency and who's there. Well, look at the difference between white, college educated, and white, non-college educated. Huge differences, and we're not talking about politics, we're talking about life streams and where people are coming from. And in each of these things, it gives you a sense of where our society is. And out of that is the next question that we want to deal with, and that is, how do we handle it? How do we deal with it? Where do we go? And this is the reason we have our experts with us. But you look at this, is it a question of prosecuting people who use illegal drugs such as heroin and cocaine, or providing treatment? And again, you look at the differences between Republicans and Democrats and independents on this, and particularly between those who know someone and those who don't. And this sort of sets up the conversation that we want to have with you. And to join us, we have three experts who want to join us up front. Jack Killorin, who is indeed the director to Atlanta to the Carolinas high intensity drug trafficking area. He's part of a 22-state consortium of heroin response collaborators. He and his team provide enforcement data to public health experts. Previously, you had 30 years, I believe, at BATF, is that correct? And indeed, working in that area, he's a Navy veteran and a graduate of St. John's University in New York. Next to him is Debra E, who is the director of the National Center for Injury Protection and Control at the CDC. Previously, she was an associate professor at the marvelous Emory University and in the Department of Emergency Medicine. And her innovative research and science-based programs are providing an important way to reduce the consequences of injuries and violence. And indeed, she's launched a very important program, which we'll talk about. And finally, we have Dave Laws with us, and we're particularly pleased to have him because he's a founding member of the Georgia Overdose Prevention. And he started this organization after losing his teenage daughter, Laura Hope, to an accident of opioid overdose. And he's been working with other parents to deal with this problem, and has passed, and he'll talk about this, an important legislation in Georgia. So as an advocate and as a parent who's dealt with this, we're particularly delighted to have them. We've talked about these problems. I would love to start with Jack, if we could. And why don't you lay out, from the public opinion data and the work that you do, how you see this problem and the numbers behind it, because you shared some of those, and those were pretty pretty amazing. And then Debra, why don't you pick it up from there? And then Dave, if you could give us sort of the personal dimension, that would be great. And at that stage, we'll open it back up.
Thank you very much. In the introduction, it mentioned I was a Navy veteran. I served in Vietnam. Over 17 years, we accumulated 58,000 dead Americans. Last year, we lost 63,000 Americans to opioid overdose. At a rate that, although there are some hopeful signs here and there, continues to increase around the country. We live in a country that has 6% of the world's population. We consume 96% of the opioid medications or opioids produced in the world. Something is particularly wrong in this country. And there's lots of perspectives in this room that we need to know about. I like to describe myself as being somewhere near the point of the lance. I'll be interested in reading the history. I'd be thoroughly interested in your explanations of the hows and whys. Right now, I'd like to turn those numbers around. And there's not much I can do for 63,000 dead people except try to stop those numbers from occurring. My reaction to the slide was very interesting. I have been in law enforcement, and this is a joke, for almost as long as there's been law enforcement at this point in time. And I see a slide that says people are saying that there's a law enforcement role in arresting substance users. Do you know who doesn't believe that's true? American law enforcement. Thank you very much. We don't believe that. We're concerned about the ancillary effects of addictive disease. We're concerned, we're coming up, or just past the Christmas season or the holiday season, in which the number of thefts from automobile at Phipps Plaza will skyrocket, and a number of the proceeds of that theft will go towards drugs. That is a law enforcement problem. The addiction that may drive someone to seek funds to feed their addiction is a disease problem. It's absolutely a disease, the evidence of disease. Gil Kurlikowski, who was the drug czar shortly after I came on board with the high-intensity drug trafficking area, used to use a phrase he called, "Be the unexpected messenger." So here I am. I'm from the police. We do not want to lock you up. What we want to do is administer naloxone and save your life on the scene. What we want to do is build systems with our partners in the community that if you are suffering from abuse, active use, abuse disorder, we want to get you into a treatment program. And we believe in you and your chance and the people you know. They can make it back. You can have a rich life. And we have other things to do. On the other side, there is a law enforcement component to this. There are gangsters, transnational gangsters. They make about $26 billion a year, primarily in Mexico, feeding our national hunger for substances to make ourselves feel better, prettier, healthier, happier, more entertaining, whatever the reasons behind it is. These are people who, if you seriously got in the way, would seriously try to take your life. And that's where law enforcement is, and that's where it belongs. So, Deb?
Ditto? No. So I think for me, how I've viewed the epidemic has really evolved, probably as the epidemic has evolved. So I was an ER doc at Grady for 15 years, and a lot of people say, we never saw this coming. And I would say, I kind of saw it coming, because you would see more and more people coming in for opioids, more and more people coming in with addiction issues or substance use disorder, and realizing there weren't a whole lot of referrals or to send people to either for pain management or for treatment. And then I would see some people that had reversed a month ago come back for another reversal and try to have those conversations. And then I decided to take a leap of faith and join CDC about 3 years ago, and undertook a little project some people now have heard of called the Opioid Prescribing Guideline for chronic pain, and led that project to where, when we take a step back and look at the numbers, Jack had shared, right now there's about 230 million prescriptions for opioids in the US on an annual basis. enough for every single adult to have a bottle of pills around the clock for 3 weeks. That's too much. And we have decreased prescribing in the past few years, but we're at 3 times what we were in 1999. So when people say we've drastically reduced prescribing, no, the curve was going like this. Now it's going like this. So there's still room to go. And my concern is that we've primed the pump. And so a lot of people became addicted to these prescription pills and then have gone on to misuse or use heroin and now fentanyl, which we know is just killing people due to the potency. So we really, got this guideline to really change practice. It's a guideline, it's not a regulation, but it's really talking about how non-opioids should be used for chronic pain first so that people have evidence-based treatment, because that's what it's about. When you look at long-term evidence for opioids for chronic pain, it's not there. For acute pain, sure. Chronic pain, the evidence isn't there. So we're trying to change the needle on that, but then we also realize there's all these people out there that currently suffer from issues with opioids, or that can go on to use or misuse opioids. So we're now funding 45 states and Washington, D.C. to develop prevention programs. We're working with health systems. And we're also doing something called syndromic surveillance, which is used for bioterrorism. Now we're using it for opioids in 32 states and not just looking at fatalities, because we were talking about we want to prevent fatalities. So looking for non-fatal overdoses in the emergency department. Like, I think y'all have probably seen the news this summer in Georgia, to where there were those fake Percocet pills. And it was a spike in syndromic surveillance. I saw, gosh, we're having more overdoses today than we should be. Really don't want to see overdoses any day, but there was a tremendous spike. And so that activated poison control, law enforcement, all the emergency departments, health advisory notices went out, worked with law enforcement, stopped that epidemic from getting worse and stop more deaths in Georgia. So that's what we're really focusing on at CDC, is really using data like this to drive action and then changing really clinical practice, focusing it based on the evidence that we have, and trying to really work through state health departments, really focusing on prevention. My goal is to prevent people from getting addicted in the first place.
Well, thank you. First, let me thank Claire and Peter for having this, and the people I'm sitting up here with, and I'm very grateful to be here today. The reason I'm here is because I'm a parent who lost a child to an accidental overdose. It happened right down the street. It happened Thanksgiving of 2013. Laura Hope was a senior in high school. That's the new face of addiction, in my opinion, and it's not unlike anybody else who has family around here. But part of her, she suffered a jaw injury, a broken jaw, right here at Decatur High School, a soccer match. She was a varsity goalie as a freshman playing against Decatur High, got a boot to the jaw. While all that sounds very innocent, it happens in sports, it's an example of how it might put a young person on a path that might not be able to get off of. And in her case, she was prescribed liquid Lortab. As a person in long-term recovery, at that time, I knew about my issues, but I didn't know the ramifications of an opioid being prescribed to a young person of age 15, what it does to the brain and how much they like it so fast and they stay on it. There's statistics that'll say if you're exposed to an opioid before 21, you have an 80% chance of a substance use disorder. If you make it to past 21, you've got an 80% chance of not suffering from addiction, from substance use, or opioid prescription turning into an addiction. So those are things that I've unfortunately learned in my journey since then. Laura's mom went to a grief group right after that, met a lady named, right over here at the church, met a lady named Robin Elliott. And Robin Elliott and Lori Fugit, who were the co-founders of Georgia Overdose Prevention, were working down in the Capitol. I joined on that team with people like Andy Gish right here, who's a RN at Northside Drive. So together, we as lay people and parents, we got a bill passed. You might have not heard about it. It's the Georgia Medical Embassy 911. Don't run, call 911. And access to naloxone, which is what Jack was saying over here. Part of that now, our mission is we've got a bill passed. Now it's our job and our mission and my passion to get the information out of how lives can be saved. Because all this stuff, we can talk about recovery and help and futures and having people pursue and finish college and become presidents of universities. It doesn't happen if you're dead. And I hate to be cold about that, but that's what happens. So in the last couple of years, this right here is the signatures of the legislators and the parents in March of 2014 when the bill was passed. Since that time, if you would put that down, since that time, there have been, from Georgia Overdose Prevention, that we know of in coordination with the Atlanta Harm Reduction Coalition, about 1,100 overdose reversals that we know about, not to mention the 174 law enforcement organizations throughout the state of Georgia that now have access to naloxone, and I'm going to say because of us, because it's the law that was passed and we help facilitate that. So that changes, what Jack was saying, changes the dynamic of an overdose scene. Police are there to help, not to hurt in that situation. It's huge. I get goosebumps talking about it. We talk about emergency room situations that you were talking about and what Andy experiences all the time at Northside Hospital. If somebody comes in with an overdose, we're hoping that there is a program, the Georgia Council on Substance Abuse has a CARES program, which is a Certified Addiction Recovery Empowerment Specialist. Those, for lay terms, are peer support. Right? There's a program now in North Georgia Hospital System where if the overdose comes in, a peer comes in and they sit with the overdose victim and they say, hey, I was you, I've been you, how can I help? So you got some comforting there. And as people in here know who have a history and know about addiction, that's one of the strongest components right now. So our main job is to keep people alive, and then maybe they can get into recovery in some different way.
And for every one of these people, it really is. The way we've been the table, average people, and the purpose of this is really to get opioids. And what I want to do is play a clip from the group that we had in Wilmington, North Carolina, so you can hear how and these are just average regular people, how they have been affected, what they're saying, and then I'd like to hear from you, and then we'll start going back and forth. What number would you say opioids as a problem here in Wilmington, in this area? What you got, Emily?
8.
10.
7.
8.
10.
I put 9.
8. 10.
9. 10.
10. 10.
Okay, so it's a huge problem here.
I am a supervisor for foster care for this county, so I have seen directly our number of children in care increase and families falling apart. I see how widespread it is and how it crosses all the different races, economic statuses, neighborhoods, areas, that it's a little bit of everybody that it's impacting.
I had a sister who was addicted to drugs of all kinds, but I remember her, when I was prescribed some Vicodin or something at one time, she said, oh, if you're not going to take that, I'll take it. It ended up partially the reason for destroying her. I mean, she ended up dying because of all kinds of health issues because she couldn't cope.
I have a close relative that came down from up north who was fighting addiction for 5 or 6 years, came down into a treatment center. Things worked well for about 8 months, and then unfortunately it didn't work out, and this individual ended up in jail.
I drive Uber, and the kids will, I drive Friday and Saturday night, like 5 till 2. The kids will sit in the back seat and just talk about all the drugs they're using or where they're going to get it or what they've done. It's the norm. It's accepted at college.
My best friend's mom, she was in a car wreck when we were like 21. So she got introduced to pain pills and she was working for a doctor, so she started stealing prescription pads and writing them, and she ended up passing away this year. I have nieces and nephews that have been strung out, panhandling at the hospital, wherever they can to get money.
Yeah, I've lost 8 friends in the past 6 months. Personally.
8 friends?
Yes. And that was all heroin. It was all heroin. But it started with opioids or this or that or something else, and it just, I mean, it got tired of getting the phone
like
calls.
You said, I mean, it's every aspect, every walk of life.
Everything, every walk of life.
talk to me about the effects in terms of not just this university, but your friends, the community, et cetera. Somebody want to start it off? Let me go a different way. I'll ask you. Okay? This is my old professor habits. Tell me what's happening, whether it's college campuses or elsewhere.
Well, even with my friends, like in school, in high school, and in college, there are people who do these kind of things. And some of my best friends have done this, and I've seen them deteriorate, like mentally, physically. And I've lost friendships with a lot of people because of this thing. Because, like, if you're doing drugs, I'm not talking about opioids specifically, but in general, like cocaine or heroin. If you do those things, you end up like meeting the same kind of people, and that tends to affect you worse. Like, then you lose your relationships with other people, and you're always with bad company, and that makes you like, that eventually, ruins your life in a way. So.
And go right behind you, hand this person. Right there. Talk about it, and talk about what you've seen, whether it is within the campus community or in community in large.
Well, so I've been out of college for 10 years. I work on campus here.
Mm-hmm.
But I think, the most striking thing to me at the beginning was when we were talking about the differences in people that view it as like an illness and people that view it as a personal individual problem. And so I think back to like my personal experiences with it, and I did end some friendships when I was in college, based on my friends snorting Vicodin and whatever, because I viewed it then as something that they were doing that I didn't want to get involved in, and their own personal choice and all that. I guess I personally think about it differently now, and I view it more as an addiction and more as an illness that they had. So. I don't know. I was trying to keep myself in that framework as I was getting frustrated, thinking about people that don't view it as an illness now and how I used to not view it that way.
Helpful. Others? Other thoughts? Yes, right here.
I work with a program here in Georgia called Motherhood Beyond Bars, and we teach prenatal classes at the Department of Corrections. The vast majority of the pregnant women in the Department of Corrections are there for drug offenses or crimes related to it. And to me, it's probably one of the most devastating views of this crisis to see a pregnant woman in prison attire serving time while she's pregnant and then being separated from her baby, and just the cycle that it creates in these families. And once you're convicted of a felon, your life is off track. It's hard to get a job, it's hard to support yourself and that child. And one of the saddest things is when I have a repeat mom in my class who's already served one pregnancy in prison.
Yeah, that's going to hurt your heart.
And today in the United States, one baby is born every 25 minutes dependent on opioids.
Just to add to the data, 25% of the babies born in West Virginia last year were neonatal abstinent at the point of their birth.
So what I heard in those last two comments was you said the word hope. That might be some change, a change of mind, a change of heart, backed by the statistics. And in some ways, it just comes back to education. The more you know, if you can get in, that it's an addiction and it's a disease, and there's ways to prevent that.
If I could ask a question, I've learned to kind of check things. We're throwing some terms out. Narcan, naloxone. Who's familiar? I see nods. Can I just get a... how many of you are aware that it's available over the counter in Georgia because of action that people like Dave?
Well, let me correct that. It's not quite over the counter.
Well, not quite.
It's a standing order. It's a standing order. You can go to your doctor and ask him for a prescription, and he'll issue it, and the governor will sign a standing order.
You can actually walk into CVS and buy it.
Now you can at CVS. That's huge.
Yeah. The point being, a lot of people seemed very close when I turned around to people who are in active use, and I don't know how close you are, but the opportunity to put a life-saving drug in that proximity, if you leave here with nothing else, the knowledge that you can pursue that or get to someone who's with that person and help them have a life-saving opportunity is not to be missed.
So the question then comes, is there a stigma attached, or is it seen as something that is a positive? I mean, if you drop back generations, you talked about birth control or those things which did or did not have a stigma. Is this have a stigma, or how do we make it as a positive that it's seen? This is something I respect rather than something I look askance at.
Wow, you guys looked at me.
Well,
and I'll answer that because I like that.
I just spoke.
Okay, we're going to order. I'm going to say about the stigma, and that's huge. Okay, I think the thing that helps in my situation was the fact that initially when we lost our daughter, I had known somebody who knew somebody who had lost a son, and they came, invited us to lunch, and sat down, and they talked about their experience, and we just listened. We had questions out the yazoo, okay? And we felt shamed. We felt like, how could it happen to us? We felt guilty, and all this stigmata that comes along with it. So the conversation then started. It is my misery turned into a ministry, so to speak, but I've been around so many people now that talk and share about it, it becomes almost common, well, it becomes commonplace, and that's a good thing, okay? Because if you don't talk about it, you don't know about it. It's a hard conversation. I applaud her opening statement about how here they do these hard conversations. There's no shame in saying, I am. There's no shame in saying, we too. You got the Me Too movement, we too. You talk about AIDS. You looked at one of those stats there that caught my eye. It was prescription drug use, misuse up here, and AIDS down here. Now, where was that 20 years ago? Damn, AIDS was up here. Prescription drugs were here. That's because of what? Because of a movement, because of a conversation, because the breaking down of the labeling. It doesn't matter who you are or what you do, but what you do causes results and consequences. So I think stigma is a big thing. Nationally, there's a group called Shatterproof that focuses on that. And it's called Shatterproof because it shatters the stigma, and families are shattered by it. So I think that there is so much hope in talking about stigma. It's kind of like right there. It's the same thing, hope and stigma. You move it, bring us out of the darkness and into the light by talking about it. Big fan of it.
And I think what I would add is one of the programs we started at CDC a few months ago is called the RX Awareness Campaign. And it is to really give the faces. Yep. And so it's either somebody that lost a parent or that themselves has, had opioid problems and either lost a job or, family, to really share those stories and put the face. So we made sure to have diverse representation, different accents, different ethnicities, things like that, so that people could see themselves in it. But then the other thing we did was we developed a toolkit. So each state can modify it, so it's got that regional flair because here we may not identify as much with somebody that's got like a thick Boston accent. You might, if you're an Emory student, but so we wanted to make sure that and communities could modify it so it links to resources. And so I think that's one way to really get people seeing and talking about it. We've actually seen numbers going up to our website after people have watched these ads. But then I also look at it from a medical perspective, and I heard a great example earlier this week about it. So if somebody came in and seen me with high blood pressure, I wouldn't say, lose some weight, eat healthy, and then come back, and I'll start you on medication, right? And so if somebody comes in after an opioid overdose or with addiction issues, I'm not going to say, come back when you're ready to deal with this. No, you're going to get them started into treatment. And so I think that's the mind that we have to have, and that's removing the stigma associated. You're treating it as the disease that it is.
And on campus, how would it be seen if you knew somebody's in opioid treatment? Seen as positive and negative, what would you be saying, thinking? Go ahead.
I think that there would still be stigma attached to it. I think that, like, in a college environment, prescription drugs are normalized in a dangerous way. People might think, oh, it is prescribed by a doctor, like, someone should take it, so it must be safe. And that's not true, and especially because even beyond addiction, it can have negative health effects. And I guess I'm curious about what duty what can Emory students do?
Very nice question, very well put together. Thoughts?
Yeah, some thoughts entirely. Do you have a safe community house for students who are in recovery? It's been a long time. I said I've been in law enforcement since we've had law enforcement. I went to college when there was only addition to study in math back in the day. But many campuses have safe community houses where students in recovery can meet free from the pressures of alcohol use and drug use that are, and we can acknowledge it's pervasive in a certain cohort of our community and on our college campuses. Those are things that students can do to help their peers. Safe disposal, clean disposal, that's kind of a public health point of view, but I would applaud anything you could do on this campus to do that. You'll see in airports safe needle disposal sites in the men's and women's or the rest facilities. These are all things that can be accomplished in the environment in which you live, all of which contribute incrementally to making this better. And I join with everyone here. Having this conversation and being willing to have this conversation and take it out of this room is really a principal part of this. You don't have to hide in corners. Be willing to engage and talk.
I'd like to. I'd like to add real quick about the on-campus stuff. There's a national trend for sober high schools, right? Recovery high schools, where you have to be in a program to get in. So you're getting everything you're supposed to at high school. A lot of these kids that go in have already had their drug run, and that's cool. They've done that. They've survived it. They've been through it. So to answer your question too, yeah, those models can be looked up and found. Kennesaw State has a huge recovery community. Now that's a community college. It used to be a small college. Now it's huge, right? But it touches a lot of, reaching out outside of here. This neighborhood is a hotbed in a lot of ways to this activity. So you can reach out with student bodies or student groups and find a connection there. Let them tell you how it works for them, and then make that model. I think it's a great idea.
And I would just say prescribers are really key in this. I think about my clinical practice. 15 years ago when I started, I assigned the prescription that came out of the computer. I didn't think about how many pills were on it, whatever the default was. Over the years, I realized that the default might be too much, and I know that Grady and potentially Emory has now changed a lot of their default settings. And University of Pennsylvania just released a study that showed, not surprisingly, that when you change the default to 10 pills, the average number of pills that started getting prescribed was around 10.
What?
So it's like what comes out of the it's what comes out of the computer. And so I think looking at what we're doing, partial fill laws, there hasn't been a lot of evidence for, and there's some issues around if you have to pay twice for it. But I think it's great for professions like dentists who might do that extra couple of days to get you through the weekend. This way, they can do the appropriate amount, and then the patient can go back if they need it. There's been some recent studies on surgeons, too, showing that more than half the patients don't use all the prescriptions that they were prescribed. And so I think if we can decrease the number of days people have it, because if you look at, once you get past like 5 days, you can become physiologically dependent. It's different for everybody.
We're going to get to that.
Okay.
It's really it's a great issue, and it's something that's very much there.
I just wanted to say that if you want to get involved, you can. Emory sort of is taking part of the lead on this. We have the Injury Prevention Research Center at Emory, and we have an opioid task force or a medication safety task force. So you can join that task force. It's wide open.
Great.
We're very integrated with the community and a lot of stakeholders in the heroin group that's in the community. So you can get involved and get in with this task force. Just let me know. I'm happy to do that. As far as Grady goes, yes, we have now started medication-assisted treatment, and that is fantastic. And we have some funding to do it for vulnerable populations who can't afford to do it typically, and a warm handoff where we actually get them started on medication while they're there in the ED, and then transfer them over into the outpatient clinic side. So there's a lot going on. We're also doing the prescription quantity issue, which has been a big problem. I think the typical at Grady used to be 30 tablets or 90 tablets. I don't remember what it was. It was something egregious, but nonetheless, we've changed that. So.
And I think it's about educating the prescribers. When we released our guideline, we had 250 nursing schools pledge. Emory signed that one. We had 60 medical schools also agree to incorporate into the curricula, and we're developing a lot of trainings to really, I think, educate people around what's appropriate prescribing.
There are villains in this.
Stop right there. Let's talk about them. Maybe we can go to the second tape. We're going to go right back to Wilmington and take a look and listen what these people are saying on how they feel.
I think a lot of it comes down to effects from the war on drugs. I think we focused on punishing people and we didn't focus on treating addiction. So now the mindset is that if someone's addicted to a drug, it's their choice. It's not something that we can do anything about or can worry about.
I think it's a social issue. Before opioids became this big hot topic in the 80s, crack was a big topic, and disproportionately African Americans were in prison for the exact same type of things that we're talking about now that we're calling mental health. It was not called mental health back then, it was called criminal activity. And a lot of communities were destroyed because of that. So every aspect of this country has to kind of come up and look at this and say, wow, we have to address this.
It is a social issue, but it is definitely an ethnic and a racial issue as well.
These are a whole bunch of different groups. Who are the two that you feel are most responsible? I want to start with James. What'd you circle?
Mainly pharmaceutical companies was the big one.
Okay, that's F. How many circled F? We're going around the table. 1, 2, 3, 4, 5, 6. I got 9 out of 12 people circled pharmaceuticals, okay? Companies, okay? Who else has got one for me?
Individuals.
I think it's the person who overuses the drug.
Okay, did I put that? Individuals who overuse, G. I've got 2, 4, 5 people, good. Who else has one?
Doctors.
Doctors. How many put down doctors? We're going 2, 4, 5, 7, 9 people say doctors. So what you're saying is doctors and pharmaceutical companies are the two groups that are worst on this. Why?
It's the money.
It's the money. What are you telling me?
That I don't think they're necessarily looking out for the good of the patient anymore because they're getting all these kickbacks from whatever prescription they're putting them on.
I think doctors now are not treating wellness, they're treating sickness. Your problem can be solved with, let's say, just an environment change or a lifestyle change. Yeah. But that doesn't make as much money for me if I give you this pill.
It's kind of swung this big pendulum. I know my mother was dying of cancer 40 years ago, and she was in the final weeks, and they didn't want to give her too much morphine because she might get addicted. Now you got this other deal where it's swung the other way. Hey, I got a little itch. Well, here's a prescription with 30 pills.
I don't think they revealed the addictiveness of some of the medications. Right. I think that the doctors thought they were helping people, and I don't know about these kickbacks. Y'all sound like we definitely know that's happening. I don't know that, but these pharmaceutical companies, they knew, or maybe they didn't know. Maybe they didn't research it long enough before it went to market.
No,
I don't know.
And I think they just, between the company and the salespeople, they don't focus on people. They don't see that they're selling drugs to people. They see their bottom line. They see the money that they're making.
I think it's personal responsibility if you decide to go to another doctor and get more pain pills because you like them. And I don't think the pharmaceutical company has anything to do with personal addiction.
A different point of view. Okay. I stopped you from villains, but I want to get into this and how you look at it and what you think needs to be done.
Yeah, and let me just pick up where I was. There are villains in this. There are villainous doctors. There are villains in pharmaceutical companies. I worry about them every day. The good news is they worry about me and my peers every day too, because we're going to get them. But there's a whole big spectrum of this where you really have to, that I'd put in a bucket mark. Oh, geez. You know, does anybody know the history of heroin? Heroin was developed by the Bayer Company at the same time they developed another product they didn't think of much called aspirin. They thought heroin would be a big winner because it was seen as the non-addictive cure to the morphine addiction that was coming out of the treatments of the American Civil War and wars in Europe. A little research gave them different information, and it turned out that the big winner was aspirin for them. Very little medical education went towards addictive diagnosis, towards addictive medications. Insurance companies thought this was good. You could prescribe pills and a dosage. It was a relatively easy claim. It was effective. Patients liked it. This is all the OGs, and someday maybe we can turn around and fix the blame. Right now, let's, again, as I started, this is the non-villainy area where Georgia has been a leader in post-education in addictive medicine for doctors in their continuation credits. There's just lots of wonderful things that are being done. Let's just turn that 63,000 down into a down spiral and save some lives. And trust me that I know the difference between poorly informed doctor and Dr. Feelgood.
Thoughts out there in terms of, yes, love to hear from you.
Hi, I'm a healthcare provider and have been out of school for a little while, not 10 years, but a little while longer than that. But what am I think it's a cultural thing. It's not just somebody to blame. When I was in school, I was taught that as long as you were in pain, you would not become addicted. And my practice has obviously changed since then. But also it's a culture of how we educate our healthcare providers. In this country, we want immediate fixes for everything. In my opinion, I wasn't trained in this country, and so my training was disease prevention and health promotion. I also came from a socialized healthcare provider. So I look at this country, and money does drive it. We want to not go to our hospitals as much because you want an immediate response, because when you do go for a follow-up, you have to pay. So you just want them in and out, make your money, and go at times. And so I think it's a whole cultural change, too. Like, what are your expectations? Are you willing to live with pain? And I think pain can sometimes be a gift that we don't even realize. There was a wonderful book called Pain, the Gift That Nobody Wants by Dr. Bradley and Yancey's. And they talk about, you know, when you have leprosy, pain, the lack of pain is a real problem. You lose a limb. But I have noticed with our patients that they don't want any pain, and sometimes part of healing and part of that pain does promote healing. So I think a cultural change and a shift in what the expectations of people are would help.
Great. A lot of hands here, and I think back there. Yep.
I'm also a physician, but I'm thinking about this more from the perspective as a patient. And I'm thinking that we need to make sure people realize there are alternatives, because as a physician who actually cannot tolerate narcotics, which is a good thing, and I've had multiple major surgeries, and I would ask the Emory physicians, so I'm glad things are changing, I hope, not to give me narcotics. And they would still just pump in the narcotics, and they'd give the prescriptions for 50. And I say, just give me 2, because I'm going to cut them in half, and I'm going to take little doses of it while I'm in acute pain. But the other thing I don't think people realize is you can actually control pretty severe pain with a combination of ibuprofen and Tylenol, and we need to do a better job educating providers and patients to do that and not get into the narcotics.
Very nice insight.
Good.
Right back here.
This relates to the comment earlier, and I clearly come from somewhere else too originally.
What? No?
And
is that South Georgia?
And to me, I'm struck by how many conversations in America about many things individualize a problem and drill down so that we see things that really relate to something larger. So for me, this issue is epiphenomenal of so much. It's epiphenomenal of our relationship to drugs in general. I mean, opioids are scary because they have such terrible results, but I worry how many of our students, are on cocaine, taking Adderall when it's not prescribed. I worry about that. I worry about why are so many of Americans feeling so desperate. that to me this is epiphenomenal of a societal illness of 21st century America that we, in a sense, refuse to address by focusing on the other things, which is not to say that opioids aren't a terrible problem, but I guess to President Sterk's earlier point, if we can't see that this is actually a scream for help, we are going to miss the boat on so much.
Very nicely stated, and right behind you. Oh, I'm sorry.
So my concern is more, is it like a chicken or the egg kind of thing with opiates? Is the doctor prescribing first, but then it's the issue of society saying pain is what the patient tells you it is, and then patient ratings and all of that in combination, and then that going towards either over-prescribing or just people resorting to heroin or theft. And I know it's kind of all over the place with that, but it all just kind of boils down to, it seems like a lot of people like to blame Big Pharma, and this is more going to turn into a question. I'd like to know what is the rate of patients who had legal prescriptions for opiates that become addicted, and that's not from like family members borrowing or stealing, that's patients who have been prescribed for like a surgery, and then after the surgery they ended up turning to something worse or non-prescribed opiates.
And what I would tell you is we don't have great data on that, and that's what the issue is. Like when we look at the incidence of new addictions in our country, we can't give you that number. We can tell you prevalence rates of addiction. And a lot of times it depends too on how long the prescription was for and the initial strength. And that's what we see makes you more likely to get addicted. Usually for somebody who's just on opioids, for chronic pain, I believe the rate is less than 2% that go on to get addicted. But when you look at how many, if you've got 235 million prescriptions out there, and you've got 2%, then that number gets big. So, for things like acute pain, opioids can be safe and they can be effective. So I'm not saying no opioids ever. I think what we have to realize is, I'd say for an initial prescription, I would not write you one for 2 weeks. I would not write you one at a high dose, because then I am putting you at risk. But so I think that's what we need to think about.
You wouldn't do it, but a lot of doctors do, because they say, hold it, the last thing I want is a call on the weekend.
Well,
yep,
so
go for it.
I would have said maybe a few years ago.
Okay.
But I'm optimistic. I'm always optimistic. I don't think I'd be doing this job if I wasn't optimistic. I've seen a lot of changes, even with the guideline when it first came out or when we were working on it. I can tell you not everybody was happy with me. I was not very popular. Now almost all medical organizations, including some of our big ones, have endorsed it. Insurance companies, including and pharmacy-based managers, are incorporating it, and we're seeing improvements. With physicians, speaking as one myself, I wanted to do the right thing. If somebody in pain, I didn't know any better. I did what I thought, as we've heard in the back, was evidence-based medicine. We've got better research now about how addictive these medications can be, and doctors are changing their practices.
Good.
To turn around one of the things you asked, we know from talking to people who have gone into treatment that 80% of our new heroin initiates are coming off prescription drug use or abuse. So we are seeing that. We understand the economic drivers. It was good to hear from Porter Jick over here, the famous quote that if we give you drugs for pain, that was widely accepted and widely promoted, that if we gave you opioids for pain, you could not become addicted. That's been largely repudiated, but it was widely put out there. And I heard some of my favorite terms, the stimulants mentioned over here. Is that Australia or South Africa?
South Africa.
That I want to tell you that the data and the law enforcement data and what we know is that stimulants are going to come at us in the coming years in an unprecedented wave that's going to make the Miami Vice days look relatively tame, relatively Mayberry-ish, but they're not going to come clean. They're going to come mixed with fentanyl and other opioid derivatives in some new hellish combination that's just around the corner from us as we work through the opioid. So I say that so that when we continue this conversation and effort, you also have some forewarning for what's coming up behind it.
And I think there was somebody
There
else
was a
up
question.
here that wanted. Yeah, right back there. Thank you.
Thank you. I'm a public health professional, and I'm an adjunct instructor here at Emory. I'm also a parent, and what struck me was Mr. Law's story about Laura. I had a 13-year-old go through a major surgery, and we got pain medication, and we needed pain medication. I think I'd be curious to know what the panelists would say now to parents who are getting those drugs for their children, because nobody told me that she needed to get off of those pain medications as soon as possible. I was fortunate in that my next door neighbor happened to be an Emory doctor, and he would check on her every day, and he's like, when can we switch over to Tylenol and ibuprofen? When can we, as soon as possible, let's think about that. And I just happened to have a personal friend who helped me, but it would have been, and her surgeon was lovely, but he didn't tell me anything about this.
And if you didn't have that friend, what would have happened? I mean, because clearly you're a concerned parent and a well-educated parent. What would have happened in terms of the
No
course?
parent wants to see their child in pain.
Uh-huh.
No parent wants to see their child cry out in pain.
So I like to take that in a little experience and what I would do now, okay? And you mentioned that. First of all, let's go to the villain thing real quick. I think everybody involved is a villain with this thing. It's the drug pharmacies, it's the people who use it, the people who sell it. But we're also in the same people, we're also the same heroes. So it's just a matter of knowing more about it and doing something about it. Okay? And that's a general statement, I know. But you can't really, I can't blame a pharmaceutical company for what happened to us. But going back to the thing about the child was prescribed, I think there's a lot of avenues to get that information out. One is with the Department of Public Health, right? If they buy onto it and they start telling people that yes, there's alternatives. Aspirin will do just fine for a tooth pull. Aspirin will do just fine for an arm break. We've all been through that. I broke 13 bones when I was a kid. I never got pain medication, all right? But I did get doped up when I had my wisdom teeth pulled out. And Mom's got a funny story about that. So, my antics when I was on that. But I think the information, if you know that you don't have to have that, ways you can disseminate that is through orientation through schools, through their health classes and all that. There's activity now going with that now. There's legislation trying to get that into public school systems, but that's real hard to do because it's a big bureaucracy. Also, I'll finish with this, is like what's old is new. We're all seeing this with our eating habits, with garden to farm to table and all that. People are growing their own stuff. That's the old way. We didn't have this problem with opioids back before there were opioids. There was pain medication, but it wasn't like that. So if you go back to some of the old thing, an ice pack, some aspirin. Now these are maybe not for chronic pain, but for the individual stuff. If you have a child, you don't need to buy into that with the doctor saying, take this, it'll be okay. Well, we all know now, just even from the news, it might not. It might be okay, but it might not. Like I said with Laura, it wasn't the cause of her overdose, but it certainly contributed to all the other factors she had with with the family tree and all that, genetics and all that. It's a contributor, right? It's not the cause. So everybody shares the blame on that. But that was a great question. How do you do?
Yes. One more question right here, and then I want to go to what are some of the other thoughts going forward and where do we want to go. And thank you all for your participation. It's been enlightening, it's been great, and it's a sense of, I think, a community coming together. It's great.
My question kind of goes off the hopelessness in America and why this is starting in the first place. And I work at the hospital. I do totally understand how people get hooked after surgeries and pain-related things. But I'd seen a town hall out of West Virginia, I think a few years ago, or maybe during the election time. And someone that spoke at that town hall was saying in her town, there were no jobs and it was really hopeless. And people just started doing opioids because out of boredom and out of no sense of doing anything else. And then people got addicted. So in, I guess, the movement to combat the crisis, is there any other, looking at some areas where there's no employment or there's no education or there's things like that, I guess, kind of thinking of it more than just drugs and doctors, which definitely is an issue, kind of thinking of it a bigger picture, I guess.
And I'd say, yes, I'm happy to talk with you more after this too, but I have all the kind of hot topics in my center. So I've got child abuse, suicide, sexual violence as well. Yes, exactly. And one of the things we're looking at is community-based interventions, because it really has to be driven at the local level. So looking at how do you build resiliency, and that's a key thing. And adverse childhood experiences, someone that has either witnessed, a parent with an overdose or violence or has experienced abuse, is going to be more likely to go on and have those issues. So how do you intervene, and we actually are funding with one of the HIDAs a demonstration project looking at that. So how do you identify people at risk or experiencing these? How do you then link them to different referrals, education, jobs? And I think that is an area to really focus on. And if you haven't read Dreamland, I highly recommend that you read that book, because it talks about how the country changed and how a lot of these small towns, they lost jobs, and there's a lot of despair. And there were some of the doctors Jack talked about, or pharmaceutical companies, or even really aggressive and smart drug cartels that capitalized on those cities of despair.
Virginia.
I'm going to diverge a little bit. I just heard some caution around that line of thinking, because that's them. You get them in the box, and they meet the perception of who should be abusing drugs. Well, of course they do. They're in a benighted community. There's no hope. There are medical professionals working at Emory Hospital who are taking advantage of their access to the medicine cabinet, are just as addicted as the poorest pregnant woman in West Virginia. And when I look at this, what we call the face of the drug crisis, I'm looking at you, and you're looking at me, and this is the face of the drug crisis. Number two, my wife and I have started to play, we call it the drinking game where we can't drink. How many advertisements for drugs are on television?
Or drug side effects.
Or drug side effects. Well, that's, I'm going to go there. Our best count is 9. We'd have passed out. If we were playing drinking game, we'd both passed out. It's 9. She's talking about the opioid constipation ads. I would love, if anybody has access to the market research. Number one, I hate the theme. It's okay to constantly take opiates. The biggest effect in your life is going to be you're constipated. But lucky you, we have this special drug that we have made and we're advertising on TV. They know the numbers better than CDC, better than NIDA, better than law enforcement, those market numbers. But an old friend of mine in the HIDA program would go to Europe as part of the anti-doping in our sports. And they would go, really, you're trying to stop drugs and you sell them to people on television.
I know when we hit constipation, it's time to go to the third. I know.
Well, we should.
If you could have one magic wand, gee, I just found another magic wand for you. What would you use it for in terms of the opioid issue?
I would use it as a platform to talk about mental health.
Right.
Because I think that's at the root of a lot of the issues that we're facing in this nation is mental health and the lack of access to it.
I would use it to kind of get rid of the stigma around mental health. I think that's really the root of the problem. You just end up with a cycle where I see every day people come in and they have some kind of a drug felony and they can't get a job, they can't get benefits, they have no option but to go back to addiction and criminal activity.
Good. Jacob?
Treat with addiction rather than incarceration.
It just doesn't start in the courthouse. You have to send the education to the school system, to the prisons and everything else. Look beyond just someone addicted to the drug, like why are they addicted to this drug?
We need money going to the drug rehabs and the places that people aren't going to be able to afford if they don't have insurance.
When you go into drug treatment, what decides whether you get well or you don't get well?
Well, I might
Personal
say,
responsibility in my book.
You can't do it on an individual basis, and trying to make families as they are have to deal with these things. Sometimes they don't have the resources or the support or the education to do it themselves because they don't know. They've been overwhelmed with the thing as well.
I'm a big believer in life enrichment and purpose. So I feel like, giving these people some kind of purpose in their life to better themselves would be a good program.
This is a series of different things that people have suggested as ways of dealing with the problem. And what I'd like to know is what are the 2 things that you think are the most important out of these 5.
More local clinics and facilities to deal with
Okay,
addiction.
did anybody else put that down as the top thing? I got 1, 2, 3, 4, 5, 6, 7 people. Okay, got it? Okay. Anybody else have something that they had as a top choice?
Education.
Education.
Okay, let's go first with education. How many said education? We got 2, we got 4, we got 6, we got 8, we got 9 people. Okay. Number 5, tougher criminal penalties for individuals who use them. Anybody else? Okay, 1. Okay. Anybody else have something that they want to put down? Annie?
Stricter oversight from the federal government.
Okay. Stricter oversight from the
pharmaceutical company.
Okay, of the pharmaceutical companies. How many hands are up on that? 1, 2, 3, 4, 5, 6, 7. Okay.
It's a complex problem, and nobody's been trying to bring all the groups together between pharma and doctors and insurance companies. I mean, I don't think there's any one person you can just laser focus on. And there's been no attempt to kind of pull together a united front. And you need some money, you need some funding to kind of fix the problem. And I don't think the government's putting much towards it.
Let's get a couple quick comments out here, and then let's close with central comments. Anybody? Right here. Thank you.
Hey, this kind of is with the whole thing. I'm an old ER nurse from Grady.
Yeah.
I was in the military when they handed out Percocet and OxyContin like Tic Tacs. I'm a provider now as a nurse practitioner with general surgery here, and we've just switched our practice to, if you have your gallbladder out, we're only going to give you 5 Percocet. Let me tell you how you're going to manage your pain. So I spend a lot of time with these patients pre and post-op, helping them take control of what their pain is going to be like and what their perception is to give them a better understanding. As a nurse and talking about education, I think I did ER nursing for 22 years. I think when we do education, there needs to be kind of a focus on the providers that are in the ER, because there is a level of compassion fatigue for these patients that were the nurses that used to get beat up when we would change their high. And I mean, these patients are very angry when you wake them up or reverse their high. But I talked to my friends who are still nurses at the bedside in the ER, and there's compassion fatigue, and I think there needs to be an emphasis on those nurses so they don't turn their heads away from the patients who have an illness and turn their backs, because I have some friends who are like, they don't need the Narcan, just let them go. They're going to come right back in here in an hour. And I don't think that's the mentality that needs to be out there, but that's what's out there.
Nicely said.
That's great. That's compassion. Change the heart.
Let me get a comment right here, and then we'll go to the panel.
Yeah, I work with spiritual health at Emory Midtown Hospital, and in addition to working with patients with addiction issues, I find myself often interacting with family members who are really wrestling with this question of how to be supportive and trying to figure out, where to set their own boundaries and how to negotiate those, with adult children who are living in the home or with employers, trying to negotiate with employees, and just how does the supportive community kind of be in relationship, but also be dealing with the negative impacts of addiction.
When we start off, we'll start in reverse. Dave,
Reverse. Okay. So again, thank you for being here. Thank you all for being here. I've learned a lot, and I hope you've gotten a little bit from what we're doing. But I want to get a couple of notes to close with here. I think part of what we can do next is just, again, I want to reference the AIDS movement, and the success that's had. There are so many successes going on a local level. Community-based organizations are one. I've already told you about the 1,000 overdose reversals we've witnessed. Those are second chances. So again, my focus with Georgia Overdose Prevention is keep them alive, and then you can get into other kinds of pain management, alternative health issues, and alternative treatments. I think governmentally and nationally, if the government's going to get involved, which I wish they don't, they should keep us giving us the money.
I'm not going to invite you again.
No. I mean, except our local representative here. And I was very grateful to be honored to speak at that prescription drug guideline thing, and that was very helpful. But what I'm saying is the funneling down of those funds and get it to the community base. That's where we're going with that, right? Because you've been very helpful. And, again, here, we're not afraid to talk openly here, right? But I'm saying, the Just Say No, we should just say no to the Just Say No campaign. That's gone. Forget about it, okay? There's a new way to looking at this thing. You've heard ideas about that. I think incarceration diversion is big. with recovery resources. The lady who on the end of the table here, I heard a big kind of like, oh my God, you kind of laughed at what she said about individual personal responsibility. I just want to ask you real quick, I'm going to challenge you. How many people in this room can stay off their BlackBerry for a day? I mean, not Facebook. Facebook is what I meant. BlackBerry. I'm not good. Those things called Facebook on BlackBerry. How many people really think they can do that for a day? Okay, there's some hands that aren't going up. Okay, so again, that's just a taste, a small taste of addiction.
Yep, thank you.
So I think it's important to realize we didn't get here overnight. People keep looking for the quick fix, and why aren't things getting better yet? We're throwing money at it. Took 15, 20 years to get here. I can tell you I spend an inordinate amount of my time on this issue and looking at it from all different areas. And yesterday I was meeting with different states, and some of the hardest hit states are starting to see decreases. And it's because they're hitting it on all fronts. They're focusing on making sure that there's safe prescribing and educating providers. But then they're also looking at innovative ways to get treatment to those who are addicted. And then, to David's point, they're making sure naloxone is available. So I think you have to prevent people from getting addicted. Those that are addicted get treatment, and then be prepared to reverse an overdose. I know that there were naloxone kits in the back, and
on your way
I
out.
keep a CPR mask, in my car and my purse all the time, because if somebody, has cardiac arrest, I want to do something. So I now have a naloxone kit as well, because if somebody overdoses, I need to be able to do something. And so I think that's how you reduce stigma is, again, you treat it as an illness, and if somebody is unconscious, you want to be able to do something. So taking a really holistic approach to it.
Thank you.
Yeah, the key is holistic. There's a conversation going on in the country. Boy, public health and public safety.
We work together.
Only got together.
Hey, wait, I'm here. I'm in there. Come on, man, pound it.
As a means of bringing together the community, and that's, if the question is who's the magic wand, you're the magic wand. All right, you're aware, you're interested in this issue. You have a defined community in which you live. There are some things specifically we talked about that be considered in the university environment to improve the atmosphere and promote people to recovery, to safety, to living. We have lots of work to do, and again, not hiding behind the bushes. My teams are not hiding behind the bushes at Emory University. They're more likely on a wiretap, brushing up on their Spanish lately. That just happens to be the way it's going, and trying to stem the source of supply and hold people accountable. The answers will be slow for a long time. It's been 10 years coming. We'll be 10 years out, and we already can see the next wave, but we're so much smarter. The personal responsibility lockup. The one thing is about that woman that said that is she's nobody's policeman. She's never been a policeman in any community to say that. We're far too aware of. You do know that to go to serious jail in the city of Atlanta, Georgia, for drug offense, that you have to do it over and over and over.
Pretty hard.
Personally annoy a prosecutor so that they recognize you when you come in. Other than that, it's, oh, for God's sakes, pay $25, get out of here. Go away. You're clogging the system. There's too much of it. So. But you're the disciplines. You need to begin the conversation here and talk about it and come to things like this and follow up and ask us more questions. And quite frankly, if you don't like what you see, and hold us to account.
Let me express thanks first to President Sterk and the administration for starting conversations, tough conversations that obviously many shrink away from. To the panel that is absolutely magnificent. You were great, you brought marvelous insights, and you brought an expertise that we needed. And everybody in the audience, thank you for participating, thank you for your help, and it doesn't stop here. This is where it should start. It's the beginning of a conversation, and an important conversation. So give yourselves a round of applause, and thank you very much for joining us.